Dementia is a feared cause of disability, loss of independence, and death. It strikes fear due to the outcomes not only of us that might experience it, but also to our family. Now, we've probably all seen the devastation that occurs with progressive dementia, such as Alzheimer's disease. But there's this new article that was titled "The Associations Between Hormone Therapy Use and Tau Accumulation in Brain Regions Vulnerable to Alzheimer's Disease." Now, that's quite a title. But this actually was sent to me numerous times. And I want to talk about this video because obviously the title strikes fear into people's hearts who are using HRT. So we definitely need to talk about that. But I also want to summarize the research around this concept of HRT being associated with an increased risk of dementia as I see it to date with other studies. I want to then come to a conclusion with you on how this type of information should be utilized in our decision-making around using HRT. Okay, so first, why all the fear? Well, the idea here comes from the Women's Health Initiative and other studies like it that have shown an increased association for women that are using hormone replacement therapy and dementia or cognitive decline. Now, if you go back all the way to the Women's Health Initiative, there actually was a separate publication, and this was the Women's Health Initiative Memory Study, or WEMS. And WEMS showed that combined therapy, again, this is not the Premarin only group or the estrogen only group. This was the Premarin and Provera, Prem-Pro group that was on the synthetic estrogen as well as the synthetic progesterone. Okay, so take that for what it is. The combined group did show what they talked about as an increased risk of dementia. And I'm going to get into kind of the details of that study and what they were actually showing. But that was the takeaway. And that's what a lot of patients were told is that, hey, if you go on this, you might have, or you will have, probably is the way it was said, you will have an increased risk of dementia. You are more likely to develop, specifically Alzheimer's disease is what they usually talk about. So before I get into the different studies and why, the takeaway may have been misleading compared to what the data actually showed, let's just talk about this hypothesis around hormones causing an increased risk of dementia, or actually causing dementia, but causing Alzheimer's disease. Because whenever we see the scientific data, like this Tau article that we're going to talk about, we always need to take a step back and say, like, okay, does this make sense? Now, this is a great parallel to the cancer conversation. And I always say this about hormones and cancer. If hormones caused cancer, we would see higher levels of cancer at periods of time in which we had higher levels of hormones. So that would be younger adults, both women and men, because of testosterone and estrogen causing cancer in adults, and that would result in cancers in younger individuals. Clearly, we don't see that. Cancer occurs at a higher frequency as we age, usually as these hormones decline. So the baseline principle here that hormones cause cancer is flawed. And then the follow-up question is do exogenous hormones, do hormone replacement cause cancer? And that's kind of a different question. But, I believe the answer is no. And I think the literature supports that. But let's go back to dementia. So same thing. If hormones caused cognitive decline, wouldn't we see cognitive decline when we actually had more hormones? Not when we don't have hormones later in life. The follow-up question to that then is, well, what about exogenous hormones? So endogenous hormones, the ones we produce, versus exogenous hormones, the ones that we actually apply. Right? So maybe there's something about the exogenous hormones that are causing cognitive decline or causing some kind of issue with the brain. That is a question worth exploring, but the foundational principle that hormones themselves cause dementia is as flawed as the foundational principle of the idea that hormones cause cancer. Okay, so let's also talk about the research around dementia in general, because this is a really hard area to study. In fact, it's a hard area even to deal with from a clinical perspective at all, because all the time patients are asking me, how can I measure my cognitive function? How can I watch for decline in cognition? Great question. And it's a great approach to monitoring your function. But the problem is we don't really have good measures for that. There are not good instruments to measure cognitive decline, especially in high-functioning individuals. So then if you have good cognitive function, there's actually there's a big margin of decline that you can go through before you would actually pick it up on something that would diagnose you with mild cognitive impairment, MCI. So it's just hard to study out of the gate. Secondly, you would need to do a large enough study and a long enough study to see decline over time. And that's why we have to rely on things like the Women's Health Initiative These studies are extremely expensive, hundreds of millions of dollars to run. And if there's no incentive to create a new product or, to show that something different is going to work better, there's really no incentive for a pharmaceutical company to do this kind of research, and it would be too expensive for anybody else to do it unless there was a lot of risk, and right now the risk is questionable. So again, I don't think we're going to see these long-term studies done. So we have to rely on what we have. So let's go back to the Women's Health Initiative. Okay, so the WHIM, so the Women's Health Initiative Memory Study. Now, this was the first large-scale randomized placebo-controlled trial assessing whether HRT actually resulted in dementia in women aged 65 and older. Okay, great. It had over 8,300 women, and they were followed for 6 years, which is a reasonably long study. How long does it take this population to develop dementia? Probably longer than that if you want to see bigger numbers, but this is how long they ran the study for. They were looking specifically at the two groups. So remember, Women's Health Initiative, you had the combined therapy group that was Premarin and Provera, Prempro, and then you had the Premarin only, which is a synthetic estrogen, but without the synthetic progesterone. What they showed is that the combined group, the Premarin and Provera together, had an increased risk of dementia. But what they actually reported, and this is a very big statistic, they said that it doubled dementia risk. But what did they actually report? Well, they used not necessarily a diagnosis of Alzheimer's or a diagnosis of dementia. They simply used a single instrument, and I already said these instruments aren't very good. They used a single instrument in one area that had only a few questions. There was a statistically significant difference. Now, I've not used this instrument personally. This isn't my field of study. But having looked at some of these instruments, these are just questionnaires, and how you answer the question is going to give you an objective score. You have to objectify it in some way. But when there's multiple areas to be studied within these instruments and only one of them is different and only one small section has clinically relevant change, is that really clinically significant? Again, not my area of study, but it certainly draws into question for me, what are we actually studying here? And does it really mean there's double the risk of dementia? All right, so let's go on to some other studies, because there are some big studies that put into question the association of exogenous hormones and Alzheimer's disease specifically. So let's talk about this Finnish study. This is one that is talked about a lot. So this is a study that looked at 84,739 postmenopausal women with Alzheimer's disease and then an equal number of controls. That's a lot of people. The study did find a small but statistically significant increase in the risk of Alzheimer's with long-term systemic hormone use. Now, that's kind of interesting. But this is a study that's done through the National Drug Registry on HRT. Now, in other countries around the world, you see a different pattern of prescribing. If you were to do the study in the US, you would have to look at what the market share is for each of these drugs, and you would see a high level of synthetic estrogens, synthetic progesterones. So whenever we're talking about big databases, we need to understand what they were using. Now, in other countries, especially European countries, we do see a higher incidence of use or a higher use percentage, a higher market share of bioidentical hormones, specifically estradiol, micronized progesterone, but they still don't get into what that is, what that market share is for Finland in this study. So now this is an interesting way to do research, because basically you're looking at a database, you're looking at a registry of users of hormones. Whenever you do that, you're going to get the things that were prescribed. So these are things that are coming through the commercial system. So in the US, it would be all commercial products that are going through the pharmacies, the commercial pharmacies. And so you would have a high prevalence of synthetic progesterone, synthetic estrogens. You would not see the bioidentical hormones that are coming from compounding pharmacies. So in the US, this would be very commercially based, pharmaceutical drug company based. Now, in Europe and other countries, it is not quite like this because there are other things that are available. There is a higher incidence of bioidenticals. In this study, they specifically list MPA, so that's medroxyprogesterone acetate, Provera. They have the WHI. And then other progesterones. We don't really know what that means. They also listed oral and topical estradiol. So hopefully we're at least getting away from Premarin and synthetic estrogens. We're talking about bioidentical estradiol, but both through oral and topical routes, probably more so patches than creams. So a couple of interesting things that come out of this study though. So number one is that they published that there was an increased risk of Alzheimer's in the hormone replacement therapy users by 9 to 17%. So That's a significant number, right? It was associated with duration of use. So if you looked at how long people were using it, the longer they used it, the higher the risk. It's interesting, right? Age of initiation, though, was not found to be associated with disease. And this is important because there are other studies that suggest that if you start it as an older woman, like they did in the WHI, that you're going to see an increased risk of developing dementia for older women starting. This study did not show that. But remember, when we talk about hormone research, we have to ask the question, what was being studied and what were they trying to find? What was the outcome they were looking for? Here, I'm not so much worried about the outcome they were looking for because they were looking at a diagnosis of dementia. But what I'm concerned about with this study is what were they actually studying? Again, there was a large percentage of MPA, medroxyprogesterone acetate, and other synthetic progesterones. So what was the impact of the medroxyprogesterone acetate on the outcomes? So there's another study worth talking about that's a large study that came out of South Korea. Now, this study included over almost 1.4 million women. So this is a massive study. And what they showed here is that the type of hormone that somebody was using was relevant to the increased risk of dementia. So this is interesting, right? This starts to ask the question, what if somebody's on a synthetic progesterone versus a bioidentical progesterone, et cetera? It doesn't answer it completely, but it gives us a glimpse. What they showed is that certain types of hormone replacement therapy, like they listed specifically tibolone, which is a synthetic progesterone, and oral estrogen, those were associated with an increased risk of dementia, but transdermal estrogen was not. And transdermal estrogens are typically going to be estradiol. This is the bioidentical form of estrogen that we want to use. So what's cool here is that it shows that this is a big study, that route matters. Synthetic progesterones and potentially oral estrogen might have an impact specifically on the development of Alzheimer's disease, but topical does not. And as you've probably heard me say, we recommend topical not only for this potential benefit, but also because it is less likely to have an impact on blood clot. And we do see there's some signal around oral that we don't see with topical. Now, age of initiation, meaning older women, actually did have an increased risk in this study compared to the study that we just talked about. So again, this signal kind of shows up, but other significant factors included socioeconomic status, education, later onset of menses, living in a rural area, late menopause, smoking. So there are a lot of other factors here that come into play, especially when you start talking about these massive databases. Now, the research around this is controversial, like I said, and this fourth study actually shows, this is a smaller study, but it shows that there was actually a decreased risk of the development of Alzheimer's disease in users of hormone replacement therapy. That's confusing, right? Now, this study showed that later initiation again did show an increased risk, but earlier use was associated with a decreased risk. And whenever I see this sort of swing in between the two, it always raises the question of, well, what's changed in that time? We know that there is an increased risk over time of cardiovascular event if a woman starts hormones later, 10 years after, 20 years after, 30 years after menopause. But I understand the physiology behind that because the arteries get harder, the plaque forms, you have other risk factors that come into play. When it comes to dementia, what happens in the brain that then exogenous hormones would be a net negative? And it's an interesting question that we don't know the answer to. And then lastly, this fifth study is just another study. It's looking at the association and it actually found that HRT was associated with decreased risk for everyone. So what does that tell us? Well, when I look at the literature, it tells me that artificial progesterone, synthetic progestins, if there is a cause, if there is a link, it's likely due to that because we know that they're devious molecules anyway, right? Increased risk of cancer, increased risk of blood clot. So could it cause issues with the brain? Yeah, I would imagine that it probably could. Oral estrogens, again, I avoid those because it's just signal. It's not a lot of signal, but there's signal that it's going to cause problems. It's going to have stronger associations with things that you don't want, and we just don't need it. So we just don't need to expose ourselves to that risk. And then finally, late initiation, is it going to be risky? I still struggle to believe that because I just don't see the mechanism behind it. So clinically, what do we do? Well, my statement for patients is, what we see in the clinic, what we see in our patients is improvement in cognitive function. I'm not measuring it. I don't have any objective data on this. I'm just telling you that patients tell me that they feel better, they think better, and they feel like their brain functions better when they're on HRT. Okay. Does that mean that we're not exposing them to risk? It doesn't, because I don't think the literature is clear. I've not seen a large enough study, a long enough study on the forms of the formulations of hormones that we're using in demonstrating risk. My guess is that we wouldn't see risk, but I can't say that for certain. Okay, so I mentioned this new study on tau, and I know I've been rambling on about all this other research, but I think it's important to lay the foundation of the conversation around hormones and dementia. So before I get to this new study though, if you are struggling to put together your own program or you're not seeing success with your bone health, if you haven't been to our masterclass, please come to our masterclass. It's an hour of your time. It's totally free. We go through the top 5 mistakes that we see so many people making as they're going through their bone health journey. And we leave a little bit of time, usually about 15, 20 minutes for Q&A. It's a great resource. If you haven't done it, I think it'd be worth your time. If you are new to the diagnosis, or if you're just not seeing the things that you're doing have the benefit that you think that they should, check us out. Link in the description on YouTube, or you can go to our website, optimalhumanhealth.com. Okay, so what about this new study? Well, I can tell you that it's striking fear in many of my patients, right? They look at this and they go, oh my gosh, here's this evidence that hormone replacement therapy causes the things that we know are associated with dementia, specifically tau. So what they do in this study? Well, in this study, they looked at the use of hormone replacement therapy and the association with not only tau, but amyloid beta. So I know we need some definitions here, right? These things are confusing. Let me just define them. So tau is a protein that is a microtubule associated protein, or an MAP. It's primarily found in neurons in the brain, and its main function is to stabilize these little tubes that help transport nutrients within the neuron, so moving things back and forth. Under normal conditions, tau is soluble, meaning that it can get absorbed into fluid, and then it binds to the microtubules, and it actually works in a good way. But in diseases like Alzheimer's disease, tau becomes dysfunctional, and it leads to this neuronal instability. And then you get these aggregates of tau that you can actually see on imaging. This results, we think, in neuroinflammation and cognitive decline. But the question is it actually causative of the dysfunction, or is this a sign of the dysfunction happening, whatever is causing the disease? And I can tell you in the Alzheimer's space, we don't really know what's causing the disease. There's people that would say it is the amyloid plaque development. People that'll say it's tau. People that'll say it's metabolic health, that Alzheimer's is actually type 3 diabetes. There's a lot of different theories out there, actually, and we don't really know. So is tau actually associated with it, or is it the things that cause the tau to get dysfunctional? Because we know that mitochondrial dysfunction will result in tau dysfunction. We know oxidative stress leads to tau dysfunction, chronic inflammation, metabolic health challenges, ApoE4, other genetic things. So if all of those things we know are also associated with Alzheimer's disease, is tau just being blamed, kind of like cholesterol and heart disease? Like it's present, but it's not actually causing the problem? Again, we don't really have the answer to this. Now, amyloid, kind of similarly. So I already mentioned this earlier. It's another protein. It's naturally produced by the brain. It's supportive and protective of the brain. But when it becomes dysfunctional, we see it with cognitive decline. And again, you can actually see this on imaging. So you can see amyloid plaque build up, and you can see dysfunctional tau build up. So this study then looked at these scans and then compared it to whether or not women were using HRT. Now, this was a very small study, 73 individuals. They were age matched to controls. They looked at amyloid and they looked at tau, and then they did this at 4.5-year intervals. The mean age of the first scan was 70. And then they did a subgroup analysis of 58 women who self-reported their exposure of hormones. Now, I'm just going to stop there for a second because I have plenty of 70-year-old patients, women in their 70s and early 80s. And when I ask them about their hormone replacement therapy history, they can tell me if they've been on it or not. But they generally will say, I don't remember exactly when I started. I think it was around this year, and I think I stopped. I think during this period I was taking this thing, and then I switched to this or that. They can give you a timeline, but it's generally not very accurate. And that really matters here. Because if you look at this data, it shows that there was an average exposure of a little over 7 years. But we're talking about women who have been post-menopause for over 20 years. So there's just an interesting lag. Now, they also talk about the lag between the initiation of hormone therapy and the first PET scan of being 19 years on average. So what I'm saying here is that there's a lot of time and not a lot of hormone exposure. So for me, the math doesn't really add up. Now, the other thing about that kind of data is that if you're just asking, are you a user or non-user? This is black and white. If you are a user, that means that you could have used it for one day. It means that you could have been on oral birth control to control some other symptoms and call that HRT, and then you would have said that you've been on that for, you're a user of hormones. So this is where we really need to be very, very clear on what people are using, and then have a big enough study to be able to do subgroup analysis of these individual things, and clearly that wasn't done here. Now, when it comes to the results, they started talking about amyloid. But the amyloid data did not show an association or a positive association with hormone therapy. They did talk about older hormone therapy users seeing an increase in amyloid beta, but when they adjusted that for their ApoE status, they found that actually that signal went away. So this was a genetic thing. This is an ApoE4 thing, not a hormone thing. Now, for tau, similarly, there was actually no main effect. They only found the effect that they reported in an older subgroup. So now we started at 74, now we're going to 58, and now we're only talking about an older subgroup, and we don't even know how many people that is. So again, this is a very, very small study. Now, the younger subgroup showed decreased tau, meaning that, again, maybe hormone therapy was protective for younger, but not for older. Again, this is a little bit confusing as how that could be the case here. So ultimately, what's the clinical impact that they're showing? They used this tool called the preclinical Alzheimer's cognitive composition test. And so this is the PACC. They used it before and after. Clinically, they were no different. So while their scans looked different at 4.5 years, clinically they were no different. I already said this is hard to study. It's hard to do this on. So was there a clinical difference that we couldn't identify? Maybe. And again, they talk about this division between older and younger, where in older women, you saw the tau develop faster. In younger women, you saw that the accumulation or the change was negligible despite hormone therapy use. So again, what does that mean? Is there something about exogenous hormones in older women? Maybe, but I think this study is way too small to say anything. Now, what they talk about at the end is that they use the cutoff of 70 years old. So they call younger women less than 70. So this is, for a lot of women, this is 20 years after menopause. So I bet a lot of women have been told if they're over 60, oh, be careful, there's this increased risk of dementia. Well, this study is showing that if you are less than 70, that there was less amyloid beta and tau development. It was protective, in other words. If you're over 70 with a late initiation, you might see an increase. But my question again would be why? Why would you see it in a 71-year-old and not a 69-year-old? Is there another factor that they're not controlling for in people over the age of 70 and women over the age of 70 that are causing this increase, and we're just not seeing the right signal when it comes to the hormone therapy? Or possibly the hormone therapy itself, the exogenous forms, if they're using synthetic progesterone, can we separate that out and see if it's coming from the form of therapy versus therapy itself? So what's my takeaway from this study? Honestly, nothing. It was so small. They were self-reporting. It was a small subgroup and then a small subgroup after that. So they took those 58 women and then divided them. I don't think they reported how many were in each group, but divided them into even smaller groups. And then they measured something on imaging that didn't show up clinically. So what does this mean for me? Absolutely nothing. This doesn't change the way I prescribe or the way that I talk to my patients about dementia and hormone therapy. We just don't know the answer definitively. But again, I can tell you clinically, people feel better, they think better, they have better cognitive function according to them. And for me, that's what matters. Now, the other component of this for me is that my patient population is women that have osteoporosis. So we already know that these women are at increased risk. We need to protect them and their bones, and hormones are a good tool for that. If dementia is a concern, this is certainly worth talking about. But again, I think this study doesn't change my mind. The bigger studies don't change my mind because of the complicated picture around synthetic progesterone, and that likely being the cause if there is any association at all, which we really can't definitively prove anyway. I can prove that hormones are great for bones and that we can help build bone at an exponentially faster rate if we're using hormones than if we're not. All right, that's it for this one. I know this was long. I'm sorry, this is an important topic, but thank you for making it all the way to the end. And remember that a diagnosis of osteoporosis isn't the end, but deciding to reverse it is a beginning. I'll see you in the next video.